Well, hi, everybody. Welcome to Habitual Excellence. I'm Mark Rabin from Value Capture. And our guest today is Donna Prosser. She is the Chief Clinical Officer of the Patient Safety Movement Foundation, an organization that we really like and respect within the Value Capture team. So before I tell you more about Donna, let me first say welcome. Thank you for joining us today.
Thanks, Mark. We're really great to be here today. Thanks so much.
Sure thing. So Dr. Donna Prosser has been in the healthcare industry for more than 30 years and is currently the Chief Clinical Officer at the Patient Safety Movement Foundation, like I said. Before that, she spent the first 15 years of her career at the bedside and then transitioned into administration after a personal experience helped her understand just how fragmented and unsafe patient care can be, unfortunately. So those experiences, as we'll hear about today, really helped light a fire and a passion in Donna for improving healthcare quality and safety. Previously, Donna worked as a healthcare consultant, helping organizations across the United States, and previously had leadership roles and or clinical roles at Martin Health System, Carteret Health Care, and Washington Hospital Center. So Donna received a doctorate in nursing practice at the University of Central Florida, a Master of Science in Nursing at Duke University, and a Bachelor of Science in Nursing at George Mason University. So Donna, you've seen the healthcare, the provision of care from so many different perspectives. A clinician, an administrator, as somebody who is at the bedside with loved ones. So from all of that background, first question for you, what inspired you? What were some of these personal experiences that really got you so involved in patient safety?
Well, Mark, as you said, I've been on all different sides of the bed now. And so back in 1997, I was a critical care nurse, working in the Washington, D.C. area. And my first husband was diagnosed with cancer. And at the time, I thought we had the best healthcare system in the world. And I was so proud to be part of that system. And then for the next 3.5 years, I sat on the other side of the bed after he had a bone marrow transplant and was chronically ill. We experienced, every segment of the continuum of healthcare during that time. And suddenly I realized, wow, how in the world do people do this who don't have the background and the knowledge that I have? And I like to say that my husband did not die of medical error. And that is great. We are so grateful that we had him for the 3.5 years that we did before he passed away. He died of his disease process, but that's only because I was there to intervene so many times at the bedside because I knew what I was looking for. So that experience really made me think, I've got to be part of the solution for this. And so I got into administrative roles starting in about 2002, right around the time that all of the quality and safety work really started taking hold. So I was really grateful that my leadership career grew right alongside the patient safety movement.
And that leadership career has taken place in the context post the IOM report of To Err is Human. Was that eye-opening and influential, or is that just part of the context of the environment now of being able to work on these challenges?
Yeah, I really didn't know a whole lot about the IOM report before I started in leadership. I don't think a lot of us did on the front lines. And so as soon as I had the opportunity, I read the report and I was checking the boxes going, yes, that happened to me. Yes, that happened to me. And so, so I think that my personal experience really helped to put into context the work that we had to do in healthcare to make it safer and more reliable. And interestingly, I worked for the next several years on various improvement teams in 2 different hospital systems, trying to improve healthcare, working with quality teams, risk management teams, and so on. And what I noticed was all of us were working really, really hard for the right reasons. This wasn't, we didn't not fix things yet because of lack of trying. And in 2015, I kind of began to understand why that might be. So at the time, I was the chief nursing officer and the site administrator for a hospital and a system down in Florida. And my husband, my second husband, was admitted to my hospital as a patient. And prior to that time, I could show you all of the graphs and all of the charts and everything that we were working on. We were doing everything that everybody else was doing to be able to say, yes, we are improving CLABSI, we're improving CAUTI, we're doing all of the right things. And then here I sat on the other side of the bed again, nearly 20 years later, and thought, we have the same problems now as we did the first time around, which is the fragmented care with the system issues that we still hadn't addressed. Yes, we had done a lot to improve performance improvement. Yes, we had brought lean healthcare into our organization and we were changing the way people thought about a culture of safety. But what we hadn't done yet was address that foundation of systemness that was still missing, and it's still missing today.
Mm-hmm. So I think we can, it would be good to talk about that systemness and how do we break down silos in care, or even break down silos in our improvement efforts. But I was wondering if Donna, if you wouldn't mind going back to talking about your first husband and his cancer treatment. You said, you posed the question, how do people do this? Well, this meaning being an advocate at the bedside. I was wondering if you could just share more about that role and what it means, or the importance of having someone there looking out for you, advocating for you.
Yeah, and it's something that I tell people all the time. When, friends or people through the Patient Safety Movement Foundation will reach out and say, I have to go into the hospital, what do I do? The first thing we say is always have somebody with you. Have somebody who's going to be your advocate. But more than that, the advocate needs to know what to look for. They need to know what questions to ask. And I think that's what I learned more than anything, was that I inherently knew the questions to ask just because I'm in the industry, just because I've been a nurse for over 30 years. So I think that is definitely something that I still worry about, that we have people in hospitals with advocates at their bedside, but if the advocates don't know what questions to ask and they don't know what clues to look for, things are still going to fall through the cracks.
And when you talked about intervening many times, I think there are things that patients or loved ones would take for granted, that if somebody is coming in with a medication, that, well, it must be the right medication and the right dose at the right time. What was it, errors like that? Or what do you remember having to look out for or intervening about?
Oh, there were so many things. So it could be from the way that the dressing was changed on his central line catheter, which was done inappropriately. It was absolutely medication reconciliation not being done appropriately, so that he wasn't on the same medications in the hospital that he was on at home, or vice versa. In some cases, it was me just knowing him and knowing how he responded to things and not being listened to. When I raised concerns and said, I am concerned that he's going to react the same way to this medication as he did to that other medication that he was allergic to, and they assured me that it was not going to happen the same way, and then it did. So, but again, I knew what signs to look for. So as soon as I began to see that that he was having some complications, I could intervene a lot earlier and a lot faster than others.
And so if a patient, let's say, is taking notes and checking things, or a loved one is there doing the same, what can healthcare organizations do to help that be a partnership as opposed to something that's viewed as maybe being somewhat adversarial?
Yeah, I think having that patient and family-centered care concept is the number one thing that I learned during my time with both of my husbands being ill. And it's something that clinicians aren't really necessarily welcoming of. I remember, when I was at one hospital and I was talking with leaders and doing an assessment of what the current state was in terms of person-centered care. And I had a physician say to me, I know what you're after. You want me to say that we're going to include the patient and the family in everything that we do. And I know that that's the right thing to do. However, really at the end of the day, I just want them to do what I say, and not, and I really, because it takes too much time and effort to include them on the team. So I think that, I was grateful to him for being honest with me. And I think that is definitely the sentiment of most clinicians and administrators, is because we really are so incredibly busy that we don't have time to slow down and explain things at a level to help them understand so they can be a part of that team. And so I think that's where the administration comes in. Let's not leave it to the clinicians to be the ones that are having to deal with that knowledge gap at the same time that we're trying to explain what is happening to a patient. That should happen from the minute the patient walks in the door of the building and goes through the entire continuum of stay.
Mm-hmm. And I mean, I like how you phrase that, being a little bit grateful that the physician was able to raise that concern. But, you mentioned lean earlier as a methodology and an improvement system. I think anytime we hear people say we don't have time to do the right things the right way, we can take a look at, well, what's consuming time? How can we eliminate waste and frustration from the day to hopefully free up the time for people to participate that way?
Yes. And there are so many things that we do in healthcare that are inefficient. And when I think about the way that we do improvement, I talk all the time about how we have to have a holistic continuous improvement framework, right? So you think about how most hospitals work. You've got a quality team, and there's a falls team and a CLABSI team and a restraints team, and so on and so on and so on. There's 50 different teams that are all doing different things to improve. They're all working really hard, but the right hand doesn't know it, the left hand is improving. And so what ends up happening is they end up competing for resources, competing for money, for time. If you have 10 different teams that all need to make a change in the medical record and they all show up at IT at the same time and say, please make my change, somebody is not going to get their changes made at the right time. The other thing that happens is then that those 10 or 40 different teams are all rolling out changes to the front line in a different way. One team says, let's make a change to a protocol. Another team says, let's write a new policy. Another team says, nobody reads any policies. Let's just put a memo on the door of the bathroom because then everybody will see it because everybody has to go to the bathroom. And so the front line is really struggling with all of these different ways that they're getting information about how it is that they're supposed to do their work. So I call those the 6 Ps of clinical practice, being protocols, policies and procedures, practice guideline summaries, patient education material, patient care documentation, and then finally professional development. Because then those teams, they all then go and make PowerPoint presentations and put them on the computer-based learning center and say, everybody please go do all of these modules. And then everybody now knows what they're supposed to do. So I think, so my 2 recommendations to healthcare systems is, make that continuous improvement as holistic as you can be so that everybody knows what is happening. And then also make it so that it's really easy for the front line to know what to do after you've made those changes.
I think that's great advice. And one other question I wanted to ask you, Donna, is, for non-clinicians who are going to be at the bedside, what can we do? Like someone like myself, if I was at the hospital with a loved one, I don't know the clinical processes. I couldn't tell you what a good wound dressing change looked like or didn't look like. I mean, do we need to try to find somebody with a clinical background to be with us, or what else can we do to help be a partner in safer care?
Well, I think there are a lot of resources through the Patient Safety Movement Foundation that are very helpful for folks. So absolutely go to patientsafetymovement.org. We have some fabulous resources. We have an app. It's called Patient Aider that somebody can download onto their phone and use while they're in the hospital. For sure, though, just knowing what questions to ask from the beginning. What should I expect? And once you're very clear on what the expectations should be, then you know what to be looking out for. So, obviously, most people know who they can ask that information of and who they can't. So, if you have a nurse that is very engaging, that you have a really great relationship with, ask that nurse, what are some of the things that you think that we need to be concerned about? And make friends, find people in the hospital who are going to be your friends and your allies throughout the hospital stay.
I had somebody a couple of months back ask a question, and I tried referring it to someone else. So maybe I'll just pass this question along to you. Let's say as a patient or as an advocate or a loved one at the bedside, you try to raise a concern and you feel like it's not being listened to. What would typically be an escalation path to try to, in some contexts, people would say, well, let me speak to the manager, hopefully in a constructive way. Like what paths are there in a hospital to try to make sure that your concerns or questions are being heard?
There's a chain of command in every hospital. And, but I love how you mentioned that we need to be constructive in the way that we're asking. Very often, the reason why people aren't getting the answers they're looking for is because they are perceived as being confrontational by the care team. I have doctors tell me all the time, they shouldn't confuse their Google search with my medical degree, right? So absolutely, we all need to be respectful of the role that each of us plays as part of the healthcare team. And so, first asking questions respectfully of the attending physician and of the nurses on the team. If you're not getting what you need there, then definitely you can escalate to the manager of that unit or the director of that unit. If you're not getting the answers that you need there, you can escalate it to the quality department, or you can make a formal complaint, usually through the risk management department. And if you're still not feeling like you're being heard, continue on and go as far as the chief nursing officer, the chief medical officer, or even the chief executive officer of the organization.
All right. Well, thank you for that, Donna. And because it can be tough to navigate, even people that say come into an academic medical center and they don't know terms like resident versus attending, and that can I think get in the way.
Absolutely, and of course it depends on who you have on the care team. So in some organizations and in some areas for cancer, for example, there's a care navigator very often that or a care coordinator or a case manager that is somebody that you can reach out to. Not every patient has one of those, but if you are lucky enough to have one, then definitely reach out to them as well.
Yeah. So Donna, you talked about the importance of having someone there at the bedside with you, but what have you seen or heard that's happened during the COVID era when there were limitations, if not complete, inability to come in as a visitor? Is that still the case, or in the context of that, what impact then does that have on the quality of care or patient safety?
That's a huge impact on quality of care and patient safety both. So and rightfully so, all the hospitals limited visitor access, which meant that the patient advocate was no longer present at the bedside. We helped a lot of people through that very difficult time because we were then learning how to have those conversations virtually. And how do you advocate for your loved one through Zoom or through FaceTime or even on the phone? So we now a lot of organizations have allowed at minimum one person at the bedside to be that patient advocate because they saw that losing that advocate was a problem. That the advocate is not there just to help the patient. The advocate is also there to help the care team. You're the eyes and the ears and the assistance that patients need when the care team can't be present. So, falls increased during the pandemic because people were trying to get out of bed by themselves. Pressure ulcers increased because people couldn't necessarily readjust themselves in bed by themselves. So many different things happened that made hospitals recognize the importance of having that advocate at the bedside. There's still, areas where that is not necessarily so. So in those cases, we did come up with a document on patientsafetymovement.org. It's called the Plan of Care Form. So if you are a loved one and you have somebody in the hospital and you can't be at the bedside, then you can use this document as a guide for the conversation that you have on a hopefully at least on a daily basis with the rest of the care team.
And we'll talk more about some of the resources, a lot of the great resources that are available from Patient Safety Movement Foundation for patients, for loved ones, for organizations. So as organizations, like you said earlier, there's no lack of effort or intent to reduce the gaps in outcomes, to work towards zero harm. It's been more than 20 years since that eye-opening Institute of Medicine report, and I think you anecdotally sort of referred to seeing problems with your first two husbands at different times. I mean, this is a broad general question, but how do you articulate the scale of the problem when it comes to harm and even death in healthcare, things that we would describe as patient safety problems? What's the scale of the problem in general? How much progress are we seeing?
We've done a lot of good things. We really have. I mean, we at least have this performance improvement focus. We have this culture of safety focus in most organizations. We didn't have that 20 years ago. So we are moving the needle a little bit. The problem is we really don't know the scope of the problem because we don't really count those statistics. So there have been several different publications that have talked about the estimates of harm. We know that here in the United States, between 250 and 400,000 people die every year because of medical error. We know that number is greater than 3 million on a global scale. We don't know really how many there are, and we do need to do a better job of calculating that data so that we can count those statistics. And we also don't know the number of people who were harmed but didn't die. I have family members that will call me and say, oh, so-and-so had a complication after surgery. She had a blood clot. I'm like, that's not necessarily a complication. It's entirely possible that was a preventable medical error. Getting an infection after surgery. People think, oh, well, that's a side effect. That happens sometimes. Not true. Usually that's a preventable medical error. And so the public, those patients survive those complications, but they're still preventable errors that they don't even know happened. So until we actually start counting those statistics, we're really not going to know the scope of the problem.
And like you said, I mean, there are estimates, and people push back on the estimates, whether it's clinicians or other leaders in healthcare, and it seems like there's this, to me, a frustrating catch-22 of not doing enough to have real data. So then the best we can do is estimates, and then poo-pooing the estimates or even arguing about the numbers. I don't think anyone's arguing that there's not a problem. I mean, if we're comparing against a goal of zero harm, we're clearly not there. I mean,
Right.
how do you, if anyone is trying to argue the numbers, how do you help redirect the conversation to the real challenge, which is not, which is getting towards zero?
Yeah, absolutely. And that's exactly how we talk about it is, one is too many. And, usually the argument that I get is, sometimes there's nothing you can do. Sometimes people get infected. Sometimes these things happen, which is true. Sometimes they do. And, but so I make it very clear that what we're talking about are preventable medical errors. So what that means to me is, for example, if I give a patient a medication and they've never received this medication before, and they have a reaction to that medication, that's not preventable. That's a terrible side effect. That's a terrible complication, but it's possible that we couldn't have prevented it because we had no way of knowing that that's how that patient would respond to that medication. However, if the patient has a documented allergy to that medication and receives it anyway, that is a preventable medical error. And so I think that's really where, when we start really calculating these statistics and becoming transparent with the data in healthcare, we need to be really clear when it is preventable and when it's not.
Mm-hmm. Well, thank you for that. That's a clear comparison, I think, of one example of preventable versus non-preventable. I've had people push back on the idea of aiming for zero. I mean, that's something where Value Capture as a firm and the Patient Safety Movement Foundation are in very strong alignment. We do advocate for going toward whether you use phrases like zero harm or the theoretical limits or ideal care. What to you, Donna, and to the foundation, why is it so important to not just emphasize on better or progress? Why is it so important to commit to working towards zero harm?
Because, as you said, but we're working towards it, right? That's what we're asking. Let's try. Let's strive for zero. Let's not strive for 10,000 people to die or 20,000 people to die. Let's strive to get to zero. So now, whether or not that happens depends on a whole host of factors. But it doesn't mean we don't try. So, I used to say, shoot for the moon, at least you'll land among the stars. And then somebody pointed out, yes, but the stars are further away than the moon. So I can't use that analogy anymore. But, yeah. But that is exactly how we see it here at the Patient Safety Movement. We want people to make a commitment to trying to get there.
Yeah, there's another expression that gets thrown around a lot. Nothing to do with astrology, but Vince Lombardi, the famed football coach, is often quoted as saying, "If you aim," so I'm paraphrasing it, but if you aim for perfection, you might achieve excellence.
Exactly. And that's exactly how we feel about that here at the Patient Safety Movement Foundation. When we do performance improvement, we all know that we're examining and assessing what is currently happening. And then we're also painting a picture for ourselves of what we want the future to be, right? And when we paint that picture for ourselves of what we want the future to be, it's usually high in the sky, best case scenario. What do we want to see? A CEO would say, we want to be the best hospital in the entire country. And we want excellent, we want the best patient satisfaction and the best physicians and so on. They don't say, well, we'll accept, 90% patient satisfaction rates. That's fine. So if we can have that ideal, that picture of the future for everything in an organization, not just financial implications, but also the safety of everybody in that organization, and not just patients. We mean clinicians as well, and visitors and vendors and anybody that walks into the doors of that hospital. Yeah.
So the Patient Safety Movement Foundation has articulated a goal of zero harm by 2030. You mentioned the moon earlier. We did a previous episode with Dr. David Mayer talking about some of the moonshot language that the foundation has been using. So in terms of that commitment to zero harm, what can organizations do? If somebody's listening who's in leadership at a hospital or a health system, or if they want to talk to their leaders, can you talk a little bit about the process for gaining these commitments to zero harm? What can people do through the foundation to state that publicly and really try to accelerate that progress?
Yeah, we want everybody to make a commitment to zero harm. So if you are a healthcare leader working in a healthcare organization and your organization has already made a commitment to zero harm, tell us about it. We're collecting the names of every hospital across the world who is striving for zero. And we have a map on our website that, we'll display your information there right alongside everybody else. If you're an organization that hasn't already made that commitment to zero, then you can access our free resources. We have what we call actionable patient safety solutions, or apps for short. Access that information, download it for free, share that with your leaders, and help them to come to the realization that we can reach zero if we do it together. It's really easy to make a commitment on our website. It's a simple form that you have to fill out, share your information with us, and then and we'll give you a little badge that says that you're committed to zero. You can put it on your website, you can put it on a billboard and tell the world, because we're also we're also talking with the public, the general public and concerned citizens, and helping them to understand how important this is. Because if they don't demand high reliability in healthcare, it's not going to happen. So there's going to come a time that patients are saying, where's your badge? Where's the badge that says that you're committed to zero? Because I heard from the Patient Safety Movement Foundation that I should be, looking for organizations that have that. So be ahead of the curve. Don't wait until after patients are already asking for it, and join us on our website.
Yeah, and I'll put a link in the show notes to that map of organizations. I mean, like you said, even as a patient, or if you've got a parent going in for a joint replacement surgery or something, like, you can go look at that map and see, and maybe make choices based on those commitments or data that hopefully would be publicly available. Because I think, maybe let me throw this at you as a question or hear your reaction. I think sometimes people assume all hospitals are equally good. I'll choose the one that's closest. I'll choose the one, or maybe it's, well, I see billboards for these, or this one has a good reputation. What are some other things from a patient perspective we can do to try to choose an organization? We can look for that commitment to zero harm. What else can we or should we look for?
The Leapfrog grades are a really great place to start as well. So, Leapfrog is a great organization that assigns a letter grade to hospitals twice a year: A, B, C, D, or F. And, obviously you want to choose somebody who has an A rating, but understand also that information is coming directly from the publicly reported data that hospitals have to disclose. So most hospitals are putting a lot of resources into improving the populations in those particular areas. But just because you're doing really good on those scores that are publicly reported doesn't necessarily mean that you have the foundation for safety across the board to support that work. And so we see that a lot in hospitals where, maybe there's been a lot of effort on the part of an improvement team. They've gotten some great results, let's say for falls, for example, and their falls rate, decreased. The team disbanded, moved on to doing something else, and then slowly over time, that falls rate creeps back up again. And that's, again, because we have been so focused on that population-specific improvement instead of creating that foundation for safe and reliable care. So they can also ask questions when they get to a hospital to say, tell me what you're doing to improve the foundation and the culture of safety in your organization.
Well,
and if the nurse says, I'm sorry.
No, go ahead.
If the nurse says, I don't know what you're talking about, I've never heard those words before, that's a clue. So
yeah, something to look out for. So thank you for mentioning the Leapfrog group. At Value Capture, we're also big fans of the work that they do. Their CEO, Leah Binder, has been a guest previously on the Habitual Excellence podcast here. So I encourage people to go and find that episode. And there are a lot of great resources from Leapfrog Group and from the Patient Safety Movement Foundation. So from a patient perspective and from the organizations. And one other thing, just want to ask before we wrap up, Donna, for the organizations that are making this commitment to zero harm, there are a number of resources then that organizations are able to tap into from the Patient Safety Movement Foundation, if you can tell us about that.
Absolutely. So once a month, we run a performance improvement workshop. So any organization that makes that commitment to zero can send the folks in their organization to that workshop free of charge. We also provide free coaching for improvement teams. So if you want to teach your improvement teams how to go through the PDSA process step by step, we can help them to do that. And it's a train the trainer approach. The idea is we'll train them and then help them to train others. So those are free to committed organizations. And we also will provide a social media toolkit to help those organizations to market the fact that you are committed to zero and share that with your community.
Well, thank you for doing that, and thank you for making that available to organizations, and all the work you're doing to help educate the public and provide resources for patients. There's a lot of great work going on. So again, the organization is the Patient Safety Movement Foundation. Their website is at patientsafetymovement.org. We'll link to that in the show notes. So our guest today has been Donna Prosser. She's the Chief Clinical Officer for the Patient Safety Movement Foundation. Donna, is there any final thought or anything else that you would want to share with the audience here before we go?
No, but individuals, we don't necessarily collect commitments from individuals, but any individual that is interested can join the community on patientsafetymovement.org and sign up for an account. You'll get our updates as well as be able to network with other like-minded individuals across the world. There's lots of opportunities to get involved as a volunteer. We are a nonprofit organization that relies heavily on our volunteer content matter experts. So please join us.
Well, I hope people will do that. So to the listeners, please go check out their website again, Patient Safety Movement Foundation. Or no, I got that wrong. It's the Patient Safety Movement Foundation. The website is patientsafetymovement.org. So Donna, again, thank you for sharing, not only, some of your own personal story and inspiration, but thank you for sharing a lot of great tips and advice for patients, for loved ones, for clinicians, for healthcare leaders. Very helpful today. Thank you.
Thanks for having me, Mark.